Hello and welcome. I am Dr. Amber Cann, and I am pleased to be reviewing today with you the pharmacologic management of NIDDM, non-insulin dependent diabetes. We also call this type 2 diabetes. I will give you a moment to review our learning objectives. Before we talk about treatment, let's briefly go over how we diagnose diabetes and what our goals for therapy are. We think about diabetes as actually a pre-diabetic condition and full-on diabetes type 2. We diagnose those conditions based on 3 different tests or 3 different factors. We'll talk about 2 of those here today. The FPG, or fasting plasma glucose, is the first factor we look at. If a patient's FPG is between 100 and 125, that indicates that they may be a pre-diabetic. If it's 126 or above, we can consider that patient not a pre-diabetic, but an actual diagnosed diabetic type 2. The other factor we consider is the A1C. And A1C, if you recall, is a good measure of long-term glucose control. It generally will tell us how the patient is controlling their glucose over about a 3-month period. So if you have a patient who has an A1C of about 5.7 to 6.4, they're in that pre-diabetic range. Then if you have a patient whose A1C is 6.5 and above, we can consider that non-insulin dependent diabetes. In most patients, we set a goal of an A1C less than 7%. We're really looking at A1C, the overall 3-month control of fasting plasma glucose. So we're using that as our benchmark to change and initiate therapy. So 7% is reasonable for most patients. Now, if you have a younger patient, maybe someone who has been newly diagnosed, has a low risk of hypoglycemia, they don't have any complications or cardiovascular disease, and the patient is motivated to be very diligent in their pharmacologic regimen, then you can set a goal for 6.5. That's not unreasonable for those types of patients. Then you can be less stringent in another type of patient. Let's say an older patient, someone with a lower life expectancy, someone with long-standing diabetes with some complications related to the diabetes, cardiovascular disease, and definitely someone who is at risk for falls or at risk for hypoglycemia. In that case, we can set a goal of below 8 for the A1C. So you have to think about the other factors in your patient's life that would indicate what type of goal is appropriate for them. Let's dive right into the pharmacotherapy for NIDDM. I've put a reference for the American Diabetes Association statement on a care plan or their standards of care for diabetic patients. So there is the reference. If you put that statement into a Google search, you will come up with their guidelines. Here is an excerpt of those guidelines from the American Diabetes Association. This is a nice algorithm for you to keep in your back pocket and have it at ready when you are deciding on treatment for a patient. It really drills down all of the recommendations that the ADA has put out there. So bookmark this page when you get to the guidelines. I know this text is small, but it's a nice pocket guide that you should have with you when you are in the clinic. We will start with how we initiate therapy for a newly diagnosed diabetic patient. Okay, so we've established that our patient has NIDDM based on those benchmarks that we talked about in the previous slides. And here's how we proceed with drug therapy based on the A1C goal that we've set for them. All right, so we said 7% is a good goal to have for most patients. So if you have a patient who has an A1C of 8.5, that's right at 1.5% above the goal, maybe a little less than 8.5. Then you would start them on metformin. Metformin is the first-line drug of choice for patients who have less than 1.5% to reduce their A1C to goal. If you have a patient whose A1C is about 1.5 or above that, but below 10%, then our starting gate is 2-drug oral therapy. For a patient who has an A1C above 10 or a blood glucose at any given time above 300, that's where we start to think about injectable therapy. Now, that could mean insulin, but that could also mean some other injectable medications as well that aren't insulin. Then, with any A1C above 11, that's really where patients have to start with insulin, maybe an injectable combo of non-insulin therapy plus insulin. Oral therapy gives us about a 1% to 2% reduction in A1C, so it's pretty modest. That's initial therapy. Then, as we titrate up doses of the medications that we've selected, maybe add on a second drug when we only started with one, we might expect another 1% reduction in A1C. So it's pretty modest. So again, just to review, if the patient is less than 8.5% A1C, then we start with metformin if it's not contraindicated. We'll talk about why that might be in future slides. If the patient's about 8.5 to 10 or somewhere below 10, you consider 2-drug therapy, starting out with 2-drug therapy. One of those drugs probably will include metformin. An A1C above 10 or at 10, that would be 2% above the goal that you've set for the patient. With significant hyperglycemic symptoms, that's where you start considering an injectable medication. It may have some, you may have some oral therapy there as well, but that's the first time we consider injectables. And then finally, if the A1C is above 11, we need to rule out type 1 diabetes, of course, but that's where insulin starts. All right, then let's think about advancing therapy. We've started our patient theoretically on maybe one drug, a metformin to start with. And then you have them back, you check the A1C, and it's still not quite below the goal or at goal where we want it to be. The first thing you should always do is check compliance. Ask the patient if they're taking their medication as you prescribed it. A lot of these medications have quite a few drug interactions, adverse effects, and so if the patient has noticed something that's making them not want to take their medication, then that could be the answer right there. It could be just as simple as switching them to something else that's more acceptable. You would also want to check their glucose testing log. They should be testing their glucose on a regular basis, so you might be able to spot a trend or see about other factors of non-compliance there. Then think about other patient factors. If the patient can't afford their medication, then the perfect drug regimen is not going to help this patient. You might also think about switching to something else that is less frequent in dosing, maybe a once a day rather than twice a day to make it more convenient for the patient. All of these things lead to better compliance and a better drug therapy regimen for the patient. So our patient has started one medication and they are not at goal. So what do we do then? How do we advance their therapy? Well, we have a number of options. So if we did not see any A1C reduction, obviously we want to look into compliance issues. If the patient seems to be compliant with their regimen, then that's a time to DC the medication that you started with and switch to something else. It just could be a not a good choice for that patient. More likely is that you'll have a modest reduction with A1C, but not quite where you need it to be. So that's where we think about 2-drug therapy, another oral medication, adding it on to the metformin. Most 2-drug regimens are always going to include metformin unless the patient has some sort of factor that makes metformin not a good choice or is contraindicated altogether. In the rare case, you might need to add a third oral medication, maybe 2 drugs on top of the metformin. You would never do that right away when adding a second tier. You would want to go slow, see what works, see what's acceptable to the patient. Diabetes is a very complicated and widespread syndrome. It's not just a matter of one organ system at play here. There's a lot of hormonal involvement, multiple organ systems, and as a result, that works well for us who are trying to treat patients because we have a number of target tissues that we can use for pharmacotherapy. The first group of drugs we're going to talk about to treat hyperglycemia are those that influence glucose uptake and utilization, and also hepatic glucose output. First and foremost, first-line therapy for most every patient is metformin. That is in a class of drugs called biguanides. In fact, there's only one drug in this class right now, and that is metformin. Metformin comes in a lot of different forms, immediate release and extended release, as well as an oral solution. Metformin works by increasing the body's insulin sensitivity. It's important to note that it will not lower blood glucose. It only increases our ability to use insulin in our tissues. Metformin is approved for use in type 2 diabetics. It also has some off-label uses, so you may see it in patients who have PCOS and infertility issues, but we're going to focus on metformin's use, of course, in diabetes. It also can be used for pre-diabetes. So we talked about those patients who are in that pre-diabetic range. Metformin is increasingly being prescribed in patients who are in that range to prevent progression to full-on diabetes. So when we start a patient on metformin, what can we expect? Typically, we will see a A1C reduction of about 1 to 2%. That's actually pretty great for patients who are in that pre-diabetic range or who are hovering around 8.5% A1C. It starts to work in a few days, and of course we don't know the effect of A1C for about 3 months, but it will be at max and its effectiveness at about 2 weeks. I mentioned earlier that there are patients that would not be candidates for starting with metformin. By and large, every patient will start except for these conditions. If you have a patient who has renal disease where their GFR is between 30 and 45, you would need to reduce the dose of metformin by 50%. So that's a half of the usual dose that you would start with. If their GFR is below 30, you just don't use metformin at all. Metformin does have a boxed warning. That is the highest level of warning that the FDA puts on medications. It relates to lactic acidosis. So it's a rare but life-threatening adverse effect of metformin. It's not something you see very often. Of course, it's rare, but it is something you need to be aware of. If the patient has a history of a metabolic acidosis state, then they're going to be more at risk for lactic acidosis. Long term, there have been reports of vitamin B12 deficiency in patients who take metformin. So, as part of a diabetic nutrition plan, they should be getting foods that have B12 in them. The most common adverse effect of metformin is the nausea, vomiting, and definitely diarrhea. This is the major reason why patients stop taking the metformin early in the therapy. The diarrhea can be pretty severe. Titrating the dose up from a low dose helps, and also selecting extended release dosage forms at first will help with that as well. But it's something that you definitely need to inform the patient about and let them know that it doesn't last for more than a couple of weeks as the body adjusts to the medication. Metformin definitely has more advantages than disadvantages. It is weight neutral. It doesn't make the patient gain weight. There are some diabetic medications that do cause some weight gain. There's a low risk of hypoglycemia. Again, it does not lower blood glucose. It makes insulin receptivity better in the human body. It seems to have a cardiovascular disease benefit in patients who are diabetic, and it's pretty cheap. There are lots of generic forms, even in the extended release dosage forms. The disadvantages, of course, are the GI adverse effects, and that can be pretty severe for patients at first in therapy. There are some kidney disease limitations, so if patients have low GFR, then they can't be put on metformin, and that black box warning about lactic acidosis is a disadvantage. The other class of drug that works on increasing insulin sensitivity is called the glitazones. It's called that because there are two drugs in this class, and they both end with the name glitazone. Those drugs are pioglitazone, that is brand name Actos, and rosiglitazone is brand name Avandia. So what can you expect from glitazone therapy? It's similar to metformin in a lot of ways, but a bit more modest reduction in the A1C, maybe 0.5 to 1.5% compared to 1 to 2 with metformin. For that reason, metformin is first-line therapy. These are secondary. And really, you would only go to these medications if the patient is contraindicated from taking metformin. The pharmacokinetics are more challenging with this type of drug. The onset takes up to 12 weeks. Now, we test A1C and see how the drug is doing overall in the 3-month period anyway, but we don't get a faster benefit in the patient's reactivity to insulin right away. It can take 12 weeks. These glitazones should be avoided in patients who have heart failure, class 3 or 4, and then also liver impairment because they are metabolized by the liver. One advantage that pioglitazone has over metformin is that it can improve diabetic dyslipidemia by increasing HDL and also lowering triglycerides. So for a patient who also has some of those other lipid disorder problems along with a diabetic condition, pioglitazone could be a good choice. Unfortunately, pioglitazone has a warning about an increased risk of bladder cancer. You definitely wouldn't want to use pioglitazone in patients who have any kind of cancer in their history, and also a family history of bladder cancer in particular. Where pioglitazone had a beneficial effect on the lipid profile, rosiglitazone does not seem to have as good of a benefit. So several studies were done, and it looks like rosiglitazone increased HDL, so that's good, but it also increased body weight in patients who were taking it. So it seems to have not as a good of a beneficial profile that pioglitazone does. However, it does not have the risk of bladder cancer that pioglitazone does have. Both of these medications have shown to cause edema in patients. They can put patients more at risk for upper respiratory infections. And in females in particular that take the glitazones, there was an increased risk of fractures. So it's something to be aware of, especially if you're treating a patient who is also at risk for osteoporosis. The main reason you'd use a glitazone is that a patient is contraindicated from taking metformin. There doesn't seem to be a decline in their effect over time, and the pioglitazone in particular can be favorable to the lipid profile. They do offer once-a-day dosing, which is convenient for the patient. However, the disadvantages are that they can cost more. They definitely cost more than metformin in the generic form, and the rosiglitazone can cause some weight gain. We're going to move on to the next class of drugs that is in our toolbox to treat NIDDM, and that is the insulin secretagogue. That's a long word for drugs that you are probably already very familiar with. Unlike metformin and the glitazones, these work in a different way. They actually do increase insulin secretion into the bloodstream and therefore reduce blood glucose directly. Drugs in this class are glipizide, glimepiride, and glyburide. These are easy to get confused, so make a concerted effort to learn the difference between these drugs, although they do work in the exact same way. They force the body to release insulin. What can we expect with sulfonylurea therapy? Well, it's about what you would expect from metformin, an A1C reduction at about 1 to 2%. We do expect a quick onset, however, 30 minutes to 3 hours, depending on the drug that you select. If you recall, the medications we've talked about before take up to 2 weeks, maybe even up to 12 weeks to work. These drugs work very quickly. The sulfonylureas have a lot more risks compared to their benefits, however. They do have a cross-sensitivity with sulfa allergies. So if you have a patient who lists sulfa as an allergy, sulfonylureas are not for them. They definitely have a high risk of cross-sensitivity and risk of an allergic reaction. These drugs also do not work in type 1 diabetics. If you remember that type 1 diabetics cannot create insulin and cannot release insulin from their beta cells in their pancreas, well, a drug that releases insulin from those structures is not going to work in that type of patient. You also would not want to give it to a patient who has a risk of diabetic ketoacidosis. The main adverse effect of sulfonylureas is hypoglycemia. It is real and it is very risky in patients who are more at risk for low blood sugars, who are elderly and at more risk for falls. These drugs can cause some weight gain because they do increase our insulin secretion, and they can have an effect of dizziness, usually related to the hypoglycemia. You can reduce this risk of hypoglycemia by selecting a extended release product. Glyburide has a long-acting dosage form. However, in elderly patients, that is not preferred, because if you put a drug that's going to be in the system for a long time and it causes hypoglycemia, then the patient is even more at risk for a bad outcome. The patient should take these medications about 30 minutes prior to a meal. Because they work so quickly, they can work right at the time that the meal is being ingested. And you would want to adjust doses based on the patient's renal and hepatic function. In general, I would not put these on the list of a drug of choice for an elderly patient, just because the risks of hypoglycemia are so great. Advantages to sulfonylureas: well, they do reduce A1C to a modest amount. They are very cheap. They're old drugs. They're well tested. We know what we can get from them. And they do offer once-a-day dosing, so they are convenient for many patients. However, again, the hypoglycemia is a huge disadvantage, and for a lot of patients, this can be risky. There are two newer drugs similar to sulfonylureas. They have the same mechanism of action. Those two drugs are neteglinide and repaglinide. Neteglinide is Starlix, and repaglinide is Prandin. These both have the same mechanism of action. They force the body to release insulin, and so you can bet that they have similar downsides as well. One benefit of these drugs is they do have a quicker onset and they don't last as long. So for someone who is at risk for hypoglycemia, this may be a better choice than the sulfonylureas because they just don't stick around as long in the body. These two drugs are really good for people who have erratic meal schedules. Maybe their job or their family life doesn't allow them to eat on a regular schedule every day. Because of the short-acting nature of both of these drugs, the patient just takes the medication when they eat, maybe 30 up to 30 minutes beforehand. Then the body is releasing insulin in response to that meal, and the blood sugar is kept lower. Similar to the sulfonylureas, these have similar adverse effects. The hypoglycemia is definitely the most troublesome. There is some weight gain associated with these medications because it is forcing the body to release insulin. Patients who were on these medications also had a higher incidence of upper respiratory infections. And then because of the way they work, they must be taken with food. They're short-acting, and so they have to be taken with food in order to reduce the blood sugar associated with that meal. Both of these drugs offer flexible dosing, so the patient can take it whenever the meal occurs. The shorter acting than sulfonylureas, there is a risk of hypoglycemia, but it is less than the sulfonylureas because it's more predictable when the effect of the drug is onset. The patient does have to take multiple daily doses, but this could be seen as an advantage as well. They do tend to be expensive. They're a lot more expensive than the sulfonylureas, for instance. Now we're moving on to much newer drug classes. The first one we're going to talk about are the incretin-based agents. So just to review our diagram again, these incretins work in two different ways. They work on glucagon secretion by reducing incretins and amylin. Those are two hormones that control glucagon secretion in the body. And then they have the benefit of appetite control as well. So before we talk about our newer drugs, let's talk about GLP-1. It is a hormone that has a lot of effects in the body. It controls insulin sensitivity in the muscle. It controls insulin biosynthesis in the pancreas. It reduces gastric emptying, helps with neuroprotection, lowers appetite, so it has some CNS effects, and it also has some cardioprotection effects in the cardiovascular system. So this is a huge wide-reaching hormone that the next classes of drugs that we talk about affects. The first class of drugs that fit into this incretin-based agent class are the DPP4Is. That stands for dipeptidyl peptidase 4 inhibitors. I often hear them referred to as the DPP4s though. And more colloquially, you may hear them just referred to as the gliptins. The reason for that is all of the drugs in this class end with the gliptin in the generic name. So what these drugs do is they prevent the breakdown of incretins, and one of those incretins is GLP-1. The drugs in this class are sitagliptin, saxagliptin, linagliptin, and alogliptin. What can we expect from the DPP4s? Well, modest reduction in A1C, really 0.5 to 0.8%, which doesn't sound like a lot, but we'll get into why they're appropriate in a moment. First, I want to mention that there are heart failure warnings for saxagliptin and alogliptin. The patients that were on these medications during clinical trials were shown to have worsening heart failure. So these drugs are not recommended for patients who have CHF or a decreased ejection fraction. It's pretty safe to say that the other drugs in this class may also have this effect. It's just that these two, when they were studied, it popped up in the clinical trials. I would just recommend not using DPP4Is at all in heart failure patients. These drugs do offer a low risk of hypoglycemia, so they are nice in that respect. They are weight neutral, so because they're not working directly on increasing insulin, they don't have that weight gain effect. Adverse effects that were seen in clinical trials were joint pain, pancreatitis, and in particular, alogliptin, there was a incidence of hepatotoxicity. So those are things rare, but things to watch out for. Now, linagliptin is the only one that does need dose adjustment in patients with renal dysfunction. So something to be aware of. The other ones don't require renal adjustments, but linagliptin does. DPP4s offer once daily dosing, so that's nice for patients. No hypoglycemia that we need to be aware of, and they are weight neutral. Disadvantages are that they are expensive. These drugs are new on the market, there are no generics, and so they are very expensive for patients who are sensitive to cost. The modest A1C reduction is probably the thing you need to be thinking about when you're prescribing them, because you just don't get that much benefit from them alone. The reason I think they do have a place in therapy is as add-on therapy. I would not call these DPP4s first-line therapy at all. They're really something that you add on to get added benefit of A1C reduction to something that is already benefiting the patient, just not to the point where they're at goal. Now we'll move on to the next class of drugs that affects GLP-1. These are the glucagon-like peptide-1 agonists. So these directly affect and agonize or increase GLP-1's actions. The drugs in this class are exenatide, liraglutide, dulaglutide, lixisenatide, and semaglutide. I'll also note that all of these, except for one, are injectable medications. So if we were following our algorithm on advancing therapy for patients who are not at goal, these would definitely not be first-line therapy. We would not start to use these GLP-1s for quite some time into therapy, and they really wouldn't be used alone. Two things of note here. The only one that is an oral therapy in this class is the semaglutide. That is under the brand name Rybelsus. And the exenatide has two different drugs, two different brand names of the same drug. One is immediate release, that is Byetta, and there is a extended release exenatide under the name Bigeron. You could probably predict that they're not first-line therapy because the A1C reduction that we can get from these drugs is about 0.5 to 1%. So they're best used when added on to something else. All of these drugs that are injectable come in pens, and they are self-contained dosage forms. The patient really has to be comfortable giving themselves injections, and they really need good patient education on how to use each particular dosage form. They do differ in how they are used between the different brand names. Here is an example of the Rybelsus dosage adjustment from the injectable form to the PO form. So they put this out for patients who were on the semaglutide in an injectable form, and then how to switch them over to the PO form, since it is a lot more convenient for patients. These types of patient-friendly and healthcare-friendly education materials are really good, actually, and you can find those on the drug company's website. So this is just to summarize the GLP-1s. You can see the only one that is available on this list as of yet is the semaglutide that is in a PO form, and it's a once daily. The other injectable medications are either once daily or the immediate release exenatide, that's BID, and then the other ones are once weekly. So even if it is an injectable, it's only a once weekly injectable. That might be more acceptable to some patients. But as you can see, they are not all of the same sort of dosage forms that can be interchanged. There's a lot of patient education that has to go along with any of these. The GLP-1s have a lot of weird contraindications and some of very rare but odd side effects as well. If a patient has a family or personal history of medullary thyroid cancer, they should not receive any of the GLP-1s, except they can use the exenatide IR, the Byetta. But all of the other ones have this warning about the medullary thyroid cancer. There's also a warning on all of them, except for the exenatide IR, for multiple endocrine neoplasia syndrome type 2. So, these are odd types of things, and for patients who have those things in their history, you would just avoid GLP-1s altogether. On the adverse effects side, GI symptoms are very, very common and can be disturbing for patients. So again, patient education, telling them about what to expect and when those side effects are going to subside, that is so important to keep the patient adherent to their medication. One great benefit for people who are diabetic in using the GLP-1s is that they do seem to cause weight loss, which is usually a good side effect for patients who are diabetic. They probably do need to lose some weight. So this is actually a nice sort of beneficial side effect that patients can take advantage of. The liraglutide actually showed in clinical trials that there was a reduction in cardiovascular risks. So that happens to be yet another beneficial side effect for GLP-1s. All of these except the one PO form are injectable, we said. There's subcutaneous injections, and the manufacturer provides some diagrams for the patient to follow, but I've just put in here that generally the injection sites are the upper arm, thigh, and abdomen. You are to rotate the injection sites daily or weekly, depending on how the drug is dosed. You don't want to inject it into the belly button, of course, and the injection needs to stay in place for 5 seconds so that all the medication is delivered into the subcutaneous tissue. The GLP-1s have disadvantages and advantages, as you might imagine. They do not cause hypoglycemia, so that's a good benefit of these types of medications. There is a possibility of weight loss, which can benefit patients that are diabetic. The once weekly dosing is very convenient for most patients. There's a cardiovascular risk reduction, specifically with the liraglutide. And now we have an oral formulation available for these drugs, so they have a lot of advantages. The main disadvantage, I would say, are that they are injectable. So for a lot of patients, this would be a non-starter. They are very expensive as well. So they are not right for every patient, but they are a new class of drugs that are pretty novel, that have some advantages, and that can be a great addition to an oral medication therapy regimen. Yet another new class of diabetic medication for NIDDM is the sodium glucose cotransporter 2 inhibitors. These are often referred to as the SGLT2. More informally, you might hear them referred as the gliflozins or the flozins because all of the generic names end in gliflozin. All of these are oral medications. So again, these are great add-on therapies for patients who are not quite at goal. Drugs in this class are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. Similar to the DPP4s and the GLP-1s, the SGLT2s have a moderate reduction in A1C that we can expect, 0.5 to 1%. So that should tell you that they are not used for single drug therapy. They are adjunctive or add-on therapy to an oral medication. All of these must be adjusted for renal dysfunction. They all have a requirement. If the creatinine clearance is below 30 mils per minute, they have to have a dose reduction. And the dose reduction is listed in the prescribing information in the package insert. So that was something you'll need to look up if that applies to a patient that you're currently seeing. Some clinical pearls about the SGLT2s. Because of their mechanism of action, they increase glucose excretion into the urine. If you were to do a urinalysis, you would definitely see urine glucose test positive for patients who are on SGLT2s. So it's something to know. You would normally be concerned about that in a patient who is not on an SGLT2, but in a patient that is on one, you would definitely expect it. They do have a nice side effect of body weight reduction, so that can be beneficial for patients. And in clinical trials, they reduce the risk of hospitalizations for heart failure. So there are some beneficial adjunct effects that happen with the SGLT2s that could benefit a lot of patients. So what would we expect for an adverse event if we're dumping glucose into the urine? Well, glucose is a great medium for the growth of fungus and bacteria. So yep, you guessed it, urinary tract infections and genital fungal infections are a lot more likely in patients who are on an SGLT2. Because we're dumping glucose into the urine, water is following that glucose because it's a large molecule. So the patient may be more thirsty, maybe increasing their urination frequency. So the patient needs to be warned that they should really stay hydrated. There are some odd warnings related to the SGLT2s. The FDA has applied some warnings related to the increased risk of acute kidney injury because we're dumping a lot of glucose into the urine. A lot of glucose is going through the kidneys, and therefore there's risk of injury to the kidneys. The other thing that's really strange is for canagliflozin only, there's a 2-fold increase in lower limb amputations. I don't know how to advise you on how to avoid this. This is just something that showed up in the clinical trials. It is something the FDA warns people about, so definitely keep that in mind when you are prescribing canagliflozin. The SGLT2s offer some great advantages. They're oral tablets, convenient for the patient, some cardiovascular benefits, specifically with the canagliflozin and empagliflozin. And they do offer the benefit of weight loss for patients who probably do need to take off weight. The disadvantages really outweigh, in a lot of cases, the advantages for these drugs. Patients going to experience frequent urination, lots of increased risk of urinary tract infections, possible acute kidney injury because of all the glucose that is being filtered out. Then there's that odd risk of lower limb amputation with canagliflozin. So again, these are not first-line therapy agents. They are really to be reserved for patients who have failed other less expensive, less risky agents. Okay, we're going to wrap it up with some other miscellaneous type agents, things that are used for diabetics, non-insulin dependent diabetics that are not insulin. These are old drugs. I don't see them used very often because we have so many more options, but they do have a place in therapy that they do offer some modest A1C reduction. I wouldn't call these first-line therapy either, but they're a lot less expensive and a lot less risky than the other add-on therapies that we've talked about. These two drugs are alpha-glucosidase inhibitors, acarbose and miglatol. Acarbose is Precoce, miglatol is Glycet. They work by inhibiting complex carbohydrate absorption. So when a patient eats a meal that has complex carbohydrates in it, it reduces the amount of those carbohydrates that are absorbed into the bloodstream and therefore would cause an increase in glucose in the blood. You can expect about a 0.5 to 0.8 reduction in A1C, which could be the thing that gets a patient over the edge into goal range when they're on something else that offers a better reduction in the first place. Because they're working in the gut, there is a lot of GI adverse events that the patient would need to be aware of. They do cause a lot of flatulence, diarrhea, bloating, and abdominal pain, and these don't go away with extended use. They can be managed, but just because of the nature of how the drug is working, that's going to be something that the patient is going to have to know about and deal with. The disadvantages of, I think, are primarily the GI adverse effects, and they do require TID dosing. So they're working alongside an actual meal that is on board, and therefore they have to be dosed with each meal. They don't really cause hypoglycemia, but if the patient is hypoglycemic, they can't, and they're taking this medication, they can't use a complex carb to increase their blood sugar. They have to use simple sugar. Usually patients know this already, but if they don't have any simple sugars or glucose tablets available to them and they try to eat a complex carb while they're taking one of these medications, it's blocking it from being absorbed. So they're not going to treat their hypoglycemic symptoms with a complex carb. This is just another piece of patient education that has to be passed on. Now, we've talked a lot about different medications and different strategies for treating non-insulin dependent diabetes. I want to bring it all together with some case studies. First, we'll talk about Bert. He's a 60-year-old male diagnosed with diabetes type 2 3 months ago. He has a history of cardiovascular disease, and he's currently on 2 hypertension medications. After 3 months of diet and exercise, his A1C is down to 9.2. His fasting plasma glucose is 230 milligrams per deciliter. So given this patient's information, what do you think is a reasonable A1C goal for Bert? And then based on our algorithm, what medication regimen do you want to start him on? So here are my thoughts on Bert. He's 60. He is relatively new in treating his diabetes. However, he does have some comorbidities with the cardiovascular disease. So in this patient, I think a reasonable goal for Bert for his A1C is 7%. And if we look at our algorithm that we discussed at the beginning of this lecture, you can see the patient is above 1.5% of his goal of 7%. So that would indicate that we start him on 2-drug oral therapy. One of those drugs, of course, unless he has any contraindications, is going to be Metformin. The other one is up for debate, but a sulfonylurea would be a cheap and convenient source for him. Since he's older, we might want to avoid sulfonylureas because of the hypoglycemia. A better choice might be nitaglinide or repaglinide. They're shorter acting and therefore are going to be less risky if they do cause some hypoglycemia. Okay, let's talk about case number 2. We have Ernie. He's an 83-year-old male diagnosed with type 2 diabetes 20 years ago. He has a history of ischemic stroke and hypertension. He's currently taking lisinopril for hypertension, warfarin for stroke prevention, and a medication that is a combo for diabetes, metformin plus glipizide. Glipizide, if you'll recall, is a sulfonylurea. His latest A1C is 7.8, and his fasting plasma glucose is 130. So what do you think is a reasonable A1C goal for Ernie? And what do you want to do with his diabetes medications? Since Ernie is 83 and he has a lot of different health issues he's dealing with, I think a reasonable goal for him on his A1C would be about 8. I mean, even 8.5, because has a lower life expectancy. He's had diabetes for quite some time, and he just has a lot of comorbidities. It would not be unreasonable to set his goal higher than the average person's. That means he's below goal in this case. So, do you want to make any changes to his medication regimen? In this case, actually, it's doing pretty well for him. It's a combination medication with the Metformin and the Glitazone. He's already below goal that we've set for him, and his plasma glucose isn't that elevated. I would honestly not mess with his medication at this point. There could be some controversy over using the Glitazone in an 83-year-old. Just in case it caused hypoglycemia, we would need to be aware of that. But if we don't have any other information that he is having hypoglycemic episodes, in this case, I wouldn't change anything about Ernie. Patient number 3 is Cookie. She is a 50-year-old female who was diagnosed with diabetes type 2 3 months ago. She has an active and busy family and social life. She loves to travel. She's proven to be highly motivated to live a healthy lifestyle. She started on Metformin 2 months ago. When we check her A1C, it is 6.9%, and her fasting plasma glucose is 101. What do you think a reasonable A1C goal for Cookie would be? Well, we said that we could set a lower goal for A1C in a patient who was younger, who was highly motivated to stick to a healthy lifestyle and a medication regimen. And this patient is, active and healthy. So I would say that even we can move her A1C goal down to 6.5. This would not be unreasonable. 7 wouldn't be unreasonable, but for her, we can be a little more conservative with her goal. Do we want to make any changes to her diabetic regimen? I mean, she's close to 6.5 already. Her plasma glucose is great. And she's on a single medication, the Metformin. Combined with a healthy lifestyle and some slight modifications to her diet, she may be well able to maintain her good work so far at 6.9 just on the Metformin. Now, we've only started her 2 months ago, and we have an A1C of 6.9. It would be worth testing her A1C again, maybe in a couple of months, to see how that Metformin is doing overall, because we really don't have a picture of A1C until we get about 3 months out, right? So in this case, I wouldn't make any changes to Cookie's regimen either. It looks like with her diet and the Metformin, she's going to be just fine. Now we have a case on Grover. He's a 60-year-old male. He's been dealing with diabetes for 4 years. He's struggled lately to be compliant with his oral meds. He asks you if there's any other medication that he doesn't have to take every day, but can also maybe help him lose weight. His latest A1C is 8.5, and his fasting plasma glucose is 275. So if he's not being very compliant, this isn't a reflection of the effectiveness of the medication he's on. It's just a reflection of him not taking his medicine every day. So what changes would you recommend taking for Grover? Well, in this case, Grover might be a candidate for the GLP-1 agonists. Remember, these are subcutaneous injections, and several of them offer once weekly dosing. If the patient isn't averse to giving himself an injection once a week, this might help him maintain better adherence to his medication regimen and also help him lose a little weight, because these GLP-1s do have that benefit. Generally, these aren't used as single therapy, so he might still have to stick with his Metformin, for instance, but it may be a lot more beneficial for him if he's not taking multiple oral medications per day. Well, I'm so happy that we could take this adventure of learning together on the pharmacologic management of non-insulin dependent diabetes. I am Dr. Amber Cann, and thank you for joining me.